just at the University of Minnesota. Stay at the podium. Okay. Oh, is the camera maybe? Okay. Okay. I'm from the University of Minnesota. I'm going to talk for the next little bit here first about really preventive therapy. So we're going to talk a little bit about the complications of the disease. And so why I think it's really important that patients and their physicians have a discussion about preventive therapy. And then that'll sort of transition nicely into the latest exciting news in congenital TTP with the FDA approval of recombinant ADAM-TS13. And I thought I'd spend some time really just talking about, what is the clinical trial like that led to the approval of this drug, because that really is what informed the label for this drug and how we use it clinically. And then thinking a little bit in the future about how, we see opportunities for this new medicine. Okay. So this is just a cartoon about how this disease works. So first, this is people who do not have congenital TTP. So you can see here in this, and I'll see if does this show up at all? No, I guess it doesn't. So in this nice cartoon, you can see blood is flowing from left to right. And you have tiny platelets. Those are the little sort of peanut-looking things there. And then von Willebrand factor, which is sort of this big sticky molecule that comes out of the blood vessel wall there and gets chopped up by the scissors, called ADAM-TS13, into more bite-sized pieces. So this allows the size of von Willebrand factor to be normal. And I think about when I teach medical students about this phenomenon in the blood, I try to use the analogy of Velcro and tennis balls. So von Willebrand factor is like this big sticky Velcro that circulates in our blood. And you can see it circulates in a folded up form so that it doesn't stick to the platelets. And ADAM-TS13's job is to chop up that Velcro into small pieces. When a blood vessel breaks, the blood flow changes, it speeds up, and that stretches out our von Willebrand factor. And so that Velcro now can stick to the tennis balls, the platelets. In congenital TTP, obviously, you don't have any ADAM-TS13. So you have what we call ultra large von Willebrand factor, big pieces of Velcro that are oftentimes kind of stuck to the edge of the blood vessel wall there. And as it stretches out, it can open up the area on von Willebrand factor and allow platelets to clump. Now, this is what we think often can lead to low platelets long-term in people with this disease, because the platelets are constantly kind of sticking to this Velcro that's in our blood. And when there's a trigger, or sometimes even without a trigger, lots of platelets can clump and cause blocking up of the blood vessel and damage to the organs. Okay. So in understanding this disease, it's really important to understand, what are the complications of the disease? Because these are the sorts of things that we want to try to prevent. This is a report that came out a few years ago from the International Hereditary TTP Registry. So some of you in this room may be part of this registry. If you're not part of this registry, come chat with me. We can get you set up on the international registry soon. This includes people from the US, Europe, Asia, all over. In this report, they asked patients, what are the times when you've had cTTP episodes? This is probably familiar to you. I'm curious, in the room, how many people had a cTTP episode at birth that you're aware of? Yeah, fair enough. Yeah. Yeah, so oftentimes jaundice at birth will be a common complication, low platelets if they're checked. Unfortunately, jaundice is just a very common phenomenon at birth, and so it's often attributed to other causes, so it may not be recognized. How about infections? How about people have had problems with infections during episodes? How about pregnancy? I've heard pregnancy talked about. Fair enough. Yeah. There's always one in the room. Sounds great. And how about alcohol use? Has anyone had an episode?
episode, or you went on a bender?
Yeah, it's a great question. We think it's usually related to a lot of alcohol use, but it's not really known. Yeah, fair enough. So these are times when we know that TTP episodes can be triggered, but you can see also there's a huge bar of there's no trigger. Yeah, go ahead.
Doc, on the pregnancy one, so is it 28 out of 130?
Oh yeah, that's a great question. So no, these are just of the people included. So people can have more than one trigger. So these don't add up to, I think there were like 120 people in this registry. So people could report, yes, I had an episode during pregnancy and infection, and sometimes without any trigger. So I think really this is what pointing out is that sometimes there's a trigger for cTTP episodes, and sometimes they just seem to come out of the blue. So before we transition to the next slide, I'm curious though, how many people in the room have at least heard about preventive therapy, had a conversation with a doctor about taking something to try to prevent a TTP episode? Great. Were those and of those conversations, were they after a cTTP episode? Usually. Okay. How about after a stroke or severe kidney damage? And then how many people had a conversation about prevention before any of those complications of the disease? No? Okay, fair enough. So let's talk a little bit about complication. So I think as everybody is aware, in this room, certainly, stroke is unfortunately a very common complication of the disease. Now you can see they broke this down in this chart a little bit by types of the genetic changes. So don't worry too much about the two different columns. But what you can see is that a transient ischemic attack is essentially a stroke that resolves on its own. So somebody would have a time period where they can't think straight, or they're having trouble moving their right arm, loss of vision, and then a few minutes, maybe an hour later, those symptoms just spontaneously go away. So from a medical standpoint, we think of it as the same disease as stroke. It just went away on its own without anyone doing anything. So you can see about 20% of people, so 1 out of 5 people had reported that during their lifetime. And unfortunately, similarly with stroke, about 20% or 1 out of 5 people had reported a stroke. Now, the next bar here, sorry for the medical lingo, but chronic renal insufficiency is another term for long-term kidney disease. So anyone in the room told that their kidney function is not normal? Yeah, it's very common with this disease. That's actually very different than the immune form of this disease, and we don't know why. Most of the time, if you have the more common immune TTP, the kidneys are very mildly injured during acute episodes and resolve within a couple of days of starting treatment. What's really unique about this form of TTP is that many patients get severe injury to the kidneys, even maybe need to go on dialysis for a period of time. Oftentimes the kidney function improves, but then people end up with this chronic renal insufficiency, or chronic kidney disease is kind of the more modern term. So between stroke and chronic kidney disease, these are sort of major concerns for us about the long-term complications. For many years, people thought about this disease really the same way as immune TTP, that if you had a TTP episode, we could treat it with plasma for a few days, everything would get better, and everything went back to normal. And I think only the last decade or so have people really recognized that that doesn't really happen. Oh, sorry.
No, keep going. I just didn't want to photograph your water.
Okay, no, that sounds fine. More recently, people have said, we think what we really want to do is try to prevent episodes and prevent some of these long-term complications of the disease. So this was a study of just people in the international registry from the US. And so this came from the University of Oklahoma. The University of Oklahoma is the headquarters for the US initiative to enroll people in the international registry. And as part of that registry, they call patients. So you may get a phone call if you're part of the registry once a year from the University of Oklahoma. And they requested all the medical records from the patients who participated in this registry and asked them, and they looked in the record for stroke. And I think what you can see here, these are the ages of the people at the time of their stroke. And you can see that people with hereditary TTP, again, a small number, but this is a very rare disease. So of the 40 people, they had their stroke at age less than 10, about 20% of the time. So that's very alarming, obviously. So these are very young ages for a stroke. And I think really called attention to the fact that we really need to do better about offering preventive therapy early in the course of the disease to try to prevent these things. In this graph, you can see the red bars are for hereditary TTP. On the right is sickle cell anemia, which a lot of us also take care of. They're very similar diseases in the sense that the strokes happen early in childhood for these diseases.
One more interruption.
Yeah.
Just for photography, I'm sorry.
I was trying to hide that. Yeah, go ahead. Sure.
Is there any correlation to the age of the patients where it drops off as they get older?
Yeah, it's a good question. That graph really just showed the time of their very first stroke. So there are just fewer people available for their first stroke as they get older. Yeah. All right. So I think really what I'm trying to show you is I think we have some really important key questions on this disease. So we've sort of established that stroke and chronic kidney disease are major problems long-term in this disease. So how do we prevent these? And I think really begs the question, should all patients go on prophylaxis? So I'm curious, are there people in the room who want to talk a little bit about their discussions about prophylaxis? Did people feel that it was something that they didn't want to do, that they were feeling resistant to? Yeah, go ahead.
I just got diagnosed Alzheimer's post-pregnancy.
Sure.
I had a lot of what other people got triggered with that never affected me, multiple surgeries, sickness, vaccines. So I didn't want to go on the prophylaxis because I was like, if I've lived this far, why would I do this?
Of course.
My doctor kind of explained, yeah, but what if you get in a car accident and you're bleeding, stuff like that. And then my baby at home and then I do it every 3 weeks, whereas I know other people in this room do it more frequently.
Sure.
So I was like, my doctor's been great, and he's like, yeah, sure, you want to do it every 3 weeks? Go for that, and that kind of made me feel better.
Yeah, fair enough. Go ahead, yeah.
So we have to come in all the time because we're 15 months old, we're pregnant at 9 months. And it's just a long life, right, to do medicine. And so our doctor's not really open to talking about stretching it or doing it less frequently. So it's kind of the reason we're here.
Sure.
Just to find out more information about what, I guess you talked about this in the presentation, but we just don't know how people know it's happening with other symptoms like just can't believe. The doctor also said they're not going to really check if people can choose as a routine thing.
Sure.
Symptoms. So we just want more information to make decisions for him long term.
Right.
So definitely conversation.
Yeah. And I think, plasma can be very cumbersome, right? Who here takes plasma as their preventive medicine? Yeah.
I did it 2 years.
Mm-hmm.
And that was extremely hard. It was every 2 weeks for 2 years. And while it was helping keep my iron normal and my platelets high, I felt like it was more taxing on my health than anything.
Sure.
Because of the lows and the dips between. But I'm on my 3rd round of Mazepa right now. And that's a lot better than plasma.
Sure. Yeah. Go ahead.
John had his last stroke was 1 year ago, 2 days on his birthday last year. The day before, he had a plasma treatment, and he still stroked out the next day while he was working out at the gym. So we watched stress as a trigger for him.
Sure. Yeah, absolutely.
He also, when I was pregnant, he also had an episode. So stress has been dehydration, and stress has been his
Sure. Yeah. In my conversations with patients about going on prophylaxis, I think the big sticking points have been every 2 weeks is a huge burden on people. To lose 1 out of 14 days to sitting in the infusion center, maybe getting pre-medications, it's a big deal to try to get that time off work, losing time with family, all those sorts of things. So I think that's number one, is just the time burden and just not feeling great after plasma. I think I hear that a lot, is they just don't feel well after plasma.
He had extreme itchy
Hmm.
after his, and that's when we were praying that it's level. And he's had 21 treatments and no reaction.
That's great.
So, praise
Yeah.
God for that.
Go
Is
ahead.
it plasma, since you're getting it from someone and everyone has different levels of Adams 13, just because I get 4 units and he gets 4
Mhm.
units, we could get it from different people, so he might be getting more than me, even though we're both getting 4 units of plasma?
Correct. Yep. It's going to vary from plasma unit to plasma unit, the same way the risk of allergic reactions and other reactions to the plasma are going to differ. So you may get a allergic reaction one time and then go multiple sessions without one because of that. So yeah.
I've
So
been getting plasma for 14 years.
mhm.
I think, and we've been as far apart as every 6 weeks to twice a week.
Sure.
So that, it has never been preventative. It's not really a preventive treatment as far as stopping the episodes, but it has made them less severe. And the other thing is
Got it.
it gives me more time to get to a hospital.
Sure.
Before we were on the plasma prophylactically, if I started with symptoms, if I wasn't in the hospital in 24 hours, I was in really bad shape.
Sure.
Now I kind of have a few days maybe that I can be stupid. But it is,
Sure.
that's just what we've been using.
Yeah, and I think it really gets to the point where plasma just isn't really a great treatment for this disease. We know that from the clinical trial, I'll talk with you a little bit later on, that when we can actually measure the levels of ADAM-TS13, and they use some pretty sophisticated tools to do that in the trial, most of the time the levels on plasma at the peak level, somewhere in the 10 to 20% range. So still not anywhere close to normal. So it's, obviously we've been waiting for a better treatment than plasma. It was just the only treatment we could offer. So I think hopefully this information is useful to you in the sense, I suspect this is probably not new to anyone in the room, but I think it is important to understand these are serious risks to your health long term. And so we should be trying to do everything we can to try to prevent episodes, but also complications like stroke and chronic kidney disease.
I'm sure we do. I just haven't been able to find it on Azuma. Standard is 40 IU per kilogram.
Mhm.
You know how much ADAM-TS13 that is?
Yeah, I'll show you some of that information. Yeah, no problem. All right. So we hit on some of these already, but I think if you're thinking about going on prophylaxis, and particularly with plasma, and we realize not everyone has access to the new drug, is what are the things that can make this drug work for you? Yes, it isn't great, but there are strategies like pre-medications, finding a schedule that works for you, and then ultimately, what is the best treatment for you? Is that plasma? There's a treatment called CoAT, that's a hemophilia drug that had been used for many years for this condition as well, or Adzimno, which people have mentioned already. I thought before we move ahead, one thing I thought I would talk about is a little bit about tolerating plasma in the hospital. So maybe just start with, if you're sick with a TTP episode and we're giving plasma in the hospital, have you had problems getting this treatment, tolerating this treatment? What have the plasma treatments been like for those of you in the hospital? Go ahead.
When I was pregnant, and at that time, TTP was just TTP, like it didn't
Mhm.
differentiate between
Sure.
C-type and TTP and ATP. I had so many reactions. I had dry nerves, my
Mhm.
blood pressure went to 54 over 30, like my brain was trying to escape my body.
Mm.
I had like hives in my throat. But when I transferred from that to just having infusions of
Sure.
plasma and found good pre-meds to take, I haven't, I have not had any issues with that.
Great. Yeah. How about others? Have you had problems with getting too much plasma, getting too much fluid? Yeah.
My first plasma exchange when I was in the hospital after pregnancy ended me back in the ICU because I got fluid overloaded. My heart rate was like 130, blood pressure tanked. My blood pressure was like 180, so it tanked to a normal level. But my doctor was like, suck it up, buttercup. This is the only treatment. Go back and do it again. But I mean, just shaking, chills, highs. I had like intense pain up my spine. It was so weird because my mom has myasthenia, so she's not plasma exchange. She was like, I feel great after my plasma exchange.
Sure.
So, but then when I went in the hospital the second time, they just did plasma infusion. I did way, I think I just got 4 bags, each day for like 6 days, and I did way better with that.
Sure.
Yeah, first time I was given plasma, I was 17. And it was a fairly new idea, and they were just putting bag after bag after bag after bag, and I got pulmonary edema, actually pretty much drowned in my hospital bed. And then they figured out that was a bad idea. But I still just get, most of the time, I still just get plasma infusions, and that works. But
Sure.
we've got where it's 4 to 6 units a day, and there's pre-meds, and it's whatever.
Right.
Until it recovers.
Yeah.
also had quite a bit of issues having plasma crisis. I
Got
answer for him
Yeah.
just because Javon half the time can't tell you what year it is.
Sure.
I'm so sorry to be so vocal with that.
Yeah.
But I'm not just a bossy wife. We've been together since he was normal into this, and life is just 100% different. So he doesn't remember things. So
Yeah.
I was there with him through.
Sure.
this.
Yeah. Sorry.
We
Yeah.
had online, so they had an allergic reaction whenever they were in the hospital as well.
Yeah. Allergic reactions are quite common. I think we often will start with plasma transfusion or plasma infusion, kind of in those, basically trying to get as much of this product transfused as possible safely. But it can be a difficult judgment. And part of the problem with this disease is that if the kidneys are injured, which is very common, then there's less ability to get rid of that extra fluid. And so then we're sort of in this rock and a hard place situation where we're trying to give more plasma to get the blood clots to dissolve, but the kidneys can't get rid of that extra fluid. And so it's very common that the doctors are trying to do the right thing, trying to give lots of plasma to make this disease resolve, but in doing so, give too much fluid, and that can cause pulmonary edema, which is the term for basically leaking of water into the lungs, because those tiny blood vessels in the lungs are kind of fragile, and so they can leak the liquid part of the blood into the lungs and cause low oxygen levels, shortness of breath, all those sorts of things. So one of the major challenges is trying to give enough ADAM-TS13, but it's in this great big bag of fluid. So plasma exchange has always sort of been our backup. By plasma exchange, we're basically making space for more fluid to be given. So instead of maybe giving 4 units of plasma over the course of a day, over the course of one plasma exchange, we can get 10, 12, 14 units. But, plasma exchange, as you're all aware, is more complicated. It requires a big dialysis catheter. You're exposed to more units of plasma. So the more exposures, the more likely you are to get an allergic reaction or other reaction to the plasma.
Question. Why not do dialysis? And I don't know which one you do first. Why not do dialysis? I know you can do this, I don't think you can do it at the same time with the plasma exchange, just to kind of help with that fluid overload.
Sure. Yeah, you can use dialysis to improve volume overload. We tend to not use dialysis in this disease unless the kidneys truly can't filter or other acid problems or other things. Yeah, with dialysis, we can remove some fluid, but plasma exchange can also, usually our goal is to try to get people to the point where they don't need dialysis, but certainly it can happen where you need both. And they kind of work, they're very similar, but work in different ways, where dialysis is good at removing water and electrolytes, and plasma is good at replacing proteins. Okay. Oh, okay, I think I somehow restarted. Okay. So I think, in terms of prevention, these are the tools that we had up until, the end of last year. So I thought I'd kind of take the second part of our discussion and maybe we can just give people a quick break to talk a little bit about the new drug. And I think some questions about how to transition from plasma, or if you're not on any prevention, how do you start therapy and what are the kind of current questions? Are there other, before we kind of take a quick break, are there other questions or things you wanted to talk about?
Last year, we were talking about microvascular, I guess, strokes.
Mm-hmm.
My question is, you said that the MRI might not be advanced enough to pick up situations.
Sure.
Okay, several points of lifetime that I experienced with Harrison. When he was 40, he couldn't move the whole left side of his body.
Hmm.
Okay, I knew something was going on, but
Sure.
they were like, he's fine, he's fine. The last MRI showed a microvascular cluster, but it was benign.
Okay. Yeah.
But it was new. What does that mean? Because
Sure.
that caught my eye. I don't like
Yeah, it's a
that.
good question. I'm not sure exactly what they saw, but certainly we can see, maybe a change in blood vessels over time.